Good afternoon. So welcome to this session. We will try to understand and address the remaining issues after TAVI and what to expect from new generation TAVI devices. The session is sponsored by Venus MedTech, and it should be fun because we're going to hear about new TAVI devices. So it's always good to have new tools that we can use to tailor the device to our patient. I will be joined today by Axel Linkert, who is going to moderate the session. And we have, you see, a very nice group of friends with Mao Chen, Jan Kovac, and Nicolas Dumontel, that you all know. What are the objectives of this session? It's really to try to understand what are the remaining issues of TAVI in contemporary practice. And second, to try to understand the challenges of TAVI in younger and, more importantly, patients at longer life expectancy, and at the end, to try to capture the features of new devices, the expansion of the portfolio with new devices that we're going to present to you today. So please take a seat. And Axel, do you want to explain once again how to interact?
Yeah, we have a chat function here, so everybody's welcome to use the app and ask questions. They will be displayed here at the screen, and we will pick up these questions and discuss it here in the team. And in addition, if there are microphones throughout the room, so if you have any question, just come up to the microphone and ask the question, and there will be time after each of the presentations to interact and discuss.
So that's perfect. So having said that, you've seen that dimension of patients with longer life expectancy has been redundant, and it's really a central theme of this year edition of PCR London Valves. So that's an issue that we have to address all together, guys. It starts by understanding what are the remaining limitations or what are the expectations that we have when we are treating a younger patients with longer life expectancy. So maybe this is the discussion that we should all try to address, to have. And maybe I'm going to start with you, Nico. When you go for a procedure, index procedure in a patient that is, let's say, 70 years old, what consideration do you have in mind in terms of outcomes?
So first, of course, the obvious one that is to achieve the best procedural outcome we can have for the immediate procedure. But I would say it's, again, obvious. But second is to anticipate the potential need for a redo TAVI intervention, considering the life expectancy of this patient. And then to have a matching between the patient anatomy and the device I will use that will let all the doors open for a potential redo intervention.
So keeping the door open for a redo procedure makes sense, and I think that's central. Jan, in terms of procedural outcomes, do you have specific expectations? What is your top priority?
Yeah, I mean, again, if you are talking younger patients, and it very often becomes a patient of choice that we really want end with no leak, whichever design matches back. We got very low pacemaker rate, and ideally want durability. I think it's part of durability is an excellent result from procedure, but one thing which is also addressed, possible with valve, we are going to discuss is also how the technology is engineers for longer durability, and there are some newcomers we had already in this meeting, how they prepare leaflet to last. So we'll get optimal result, which can get us somewhere, but to make it longer, really it needs to be technology itself.
So I've heard redo, keep the door open for redo. I have heard low pacemaker rates and technology that really fits to the patient, okay? So Axel, you have a vast experience with TAVI. So now what is, to your experience, the top one priority when it comes to the procedure?
Yeah, I think the implant has to be as perfect as a conventional surgical valve. So this means no pacemaker acutely, no paravalvular leak, no procedural mortality, and anatomical orientation. Because this is, if you're setting the base for this during the initial deployment, then valve and valve implantation in the future is no issue. Then the other point, over the long-term durability, we want the valves to last for 20 years, if possible. And in order to achieve this, we need low gradients with no risk of early deterioration, no risk of thrombus formation on the valve.
So it's quite interesting because as a metric, as a reference, you said like 20 years durability. If we take the Swedish data, when you are 70 to 75 years old, your life expectancy is somewhere between 10 and 12 years. So do we need such a long durability, or is 10 years durability data, as we had recently from the literature, is enough?
I mean, this is an interesting point you're raising. I mean, with regard to the technical aspects, it doesn't make a difference if you're treating somebody that is 50 or 75. So, I mean, the procedure is the same. It all comes to valve durability. We can discuss whether in an elderly patient, a valve that is not that lasting but less costly would be appropriate. And for a patient that is younger, we have the valve that is long lasting. You know, there are different calls on the streets, right? And people select, based on their preferences. And maybe, I mean, costs in the healthcare system are increasing, and we have to deal with the money and with the availabilities in an appropriate way. So maybe we have to rethink this concept, and not one valve fits all of the patients, right?
And Mao, procedural-wise, what is your top priority when you do a TAVI procedure?
Yeah, to me, I think the non-durability is absolutely a very important issue. But to me, I think the immediate effects and the safety is the major question we should consider. Especially in China, we have some spatial anatomic patients, so we must pay attention just because we didn't have solid evidence to support like a bicuspid. So this is another question we should pay attention.
So you want durability as well? It's being a quite constant theme through the discussion. You want a device that is quite versatile and remains safe even in more complex anatomies like bicuspid, lot of calcium. There is something that didn't come out at all, and maybe we can poll the audience. It's paravalvular regurgitation. Is it still an issue? Do you still worry about PV leak? Raise your hand. So almost very few. So it tells us that potentially the devices that we have today are efficient because we don't get paravalvular regurgitation. But if we try to summarize what we've got from that very, very nice discussion, is that if we think about a maybe not new generation TAVI device, but something that is contemporary, it should be a device that keeps the door open for a redo procedure. We're going to elaborate more on that during the session. We want a device that mimics surgical outcomes, as you said, Axel, and it means proper commissural alignment. Regurgitation is not an issue, but you said, Jan, low pacemaker rate. And you said, Mao, the device that respects the calcium, but achieves enough circularity even in that very complex situation. Okay. So I think that this is what we want in terms of wish list. Let's see if what we can obtain from these newcomers, new TAVI devices that we have from the Venus MedTech portfolio. So we have a case.
Okay, so thank you very much again. Thank you, Didier and team. So yeah, this case in the box, which relates to one of early cases on this new technology of Venus Vitae, which is a balloon expandable valve, as you will see in a moment. These are my conflicts. So I'm part of a clinical research team for plant studies, about which you will hear earlier. So this is patient is from Caribbean, actually. Case was performed in Caribbean, as I show you later. Slightly younger patient, 69 years old, female, which presents with progressive fatigue, tiredness, dyspnea, with heart failure, and was admitted actually for heart failure decompensation. As you can see, it's despite a young age, they've got quite a few comorbidities, and he's got additional degree of mitral regurgitation, and he's actually already shows sign of left ventricle dysfunction, ejection fraction about 30%. It's on combined anti-failure therapy. Echocardiogram shows there is, as I said, reduced ejection fraction. There is a severe aortic stenosis, which index quite tight, 0.4 square centimeters. Gradient still maintained somewhat in that poor function. You see left ventricle hypertrophy and strain on ECG. The valve, and we'll allude to it later, it's area-derived diameter. That's how we decide about sizing. Here you see the CT scan, which suggests measurement with area 470 plus square millimeters, derived diameter 24.5, eccentric 21 by 27, minimum maximum, and from that averaging 24.3. We measured LVOT below, which is spacious, so we don't have any LVOT narrowing or obstruction, which is good for procedure. They got rather spacious sinus of Valsalva, good size.
If you just come back, I would like to have your view on that. Do you think that it's a tricuspid or a bicuspid, Mao?
Yeah.
Young patient.
Yeah, just a little bit roughy in the left and right coronary. So to me, I think it's type 1.
Nico?
I would have expected a type 1. Yeah.
That was, you passed. Yeah, I'll show later.
So a complex anatomy.
Yep, it's again height. Again, this is going to be balloon expandable, so you need a little bit of height, which is similar to other balloon expandable valves. And yeah, it's all this close to you. So it's calcified, mild to moderate, mild calcification levels, but it's bicuspid effusion between right and left coronary cusp. Again, you see the morphology, the position which was chosen by implanters. Again, like kind of three sinusoid view. It's almost AP with slight areal, slight cranial. That was the plan for a procedure of the case for this particular valve. Femoral, again, we need for valve size which we choose, we need 5.5 millimeters, so it's again in line with other valves. If it's bigger, we need slightly bigger. But you see that peripheral access is spacious, could be even spacious if we needed bigger size the valve. Here, see sizing, there's no completely official nominal, but it's, as I said, annulus area derived, the diameter, and it falls in the group 21.7 to 25, so it's the venous vitae valve of 26 millimeter. In planning for procedure, our operators made a decision about inflation device with the amount of contrast and atmosphere we will deliver, which we'll show you later in the case and when the device will be presented. So plan for this one to use and deploy venous vitae 26 millimeter valve via a right femoral approach. Thank you.
Thank you, Jan. So do you want to maybe introduce, Axel, the platform, because it's new? We had a kind of very strong wish list, and let's see if the features of that device may apply to what we expect for this type of patient.
Yeah, so this is a venous vitae tower system. As you can see, it consists of a few devices. It's the crimper to the left, then it's the valve itself, it's the Absopath introducer sheath, the balloon inflation device, and the Navimaster THV delivery system. The valve is made out of porcine pericardial tissue, and it has an innovative anti-calcification technology, and it's a dry tissue valve. The frame has a relatively low height, between 14 and 21 millimeter, and it's made out of cobalt chromium and comes with a high radial strength. There's an adaptive seal at the bottom that works like a sponge to avoid paravalvular leaks. And there are additional 3 gold radiopack markers that allow for commissural alignment and anatomical correct implantation. And there are special features on the backside of the catheter that help you to fine-tune the position of the valve and to rotate the valve in the correct position. The valve, when it comes out of the sheath, is covered by a capsule. This is intended to avoid any interaction between the valve frame and the aorta, and avoid scratching of sclerotic material and pushing it up all the way to the ascending aorta. There's a telescoping knob at the end for fine-tuning of valve depth, and there's a rotational feature at the end to allow for anatomical positioning. In addition, there's a locking wire that prevents the valve from diving during implantation. Once again, you can see here illustrated the radio pack markers, 3 gold markers, in the 3 different lease nets. And there's a rotational capability of the Y connector at the distal end of the catheter. So you can choose for like an overlay of the left and non-coronary cusp and the right cusp to the left on the picture, and then you achieve overlay of the 2 gold markers on the left side, and this means you have achieved commissural alignment. And if this is not the case, you can turn the Y connector at the distal end to achieve this commissural alignment. And by the fine-tuning knob, you can position the valve. Once again, the catheter with the steering knob here to bend the catheter and nicely pass the valve through the arch. There's this telescoping knob at the end to fine-tune the valve depth. And as you can see, the valve comes in 4 different sizes from 20 to 29 millimeters. And the frame height depends on the valve size, and from 14.4 to 20.7 millimeters. Last but not least, there's this crimping device that helps you to crimp the frame on the balloon. There's the inflation device on the lower left, and in addition, there's this hydrophilic covered sheath with a dilator and an innovative membrane sealing at the end to avoid bleeding from the sheath. Thank you.
So thank you, Axel. So we have the data. We have the data from the patient. We have the device that is going to be utilized. So let's have a kind of heart team, improvised heart team. So let's discuss about what we're going to do for this patient, because it's a 69 years old female, bicuspid type 1 left to right with this calcific pattern. Mao, you have quite a large experience with bicuspid patients. So would you go for a direct procedure, direct implant, or would you go for a pre-dilatation? And how would you do?
Yeah, I think to this particular patients, just because they reduced the left ventricular ejection fraction, I think the TAVI is optimal procedure to this patient, the first thing. The second thing, just because the raphe is shorter and no very severe calcification, I think each device can be used to this particular patient. And I think if we want to use a self-expanding device, absolutely pre-dilation for these patients. But to balloon expandable, it depends on just maybe the direct hemodynamic monitoring can give us more information. We do pre-dilate or not.
Okay, so you would pre-dilate even though the anatomy is overall favorable with a raphe that is not that long. Yeah. So you expect that the expansion is going to be nice with any kind of device.
Sure.
So a balloon expandable for this patient makes sense?
Yeah.
Yeah?
Yeah, but balloon...
You may disagree, yeah? It's an open discussion.
Yeah, I think to balloon implantable, maybe just because the so strong dilation, not all patients were using the predilation, but to self-expanding, always we lead the predilation, just make sure the very good shape is personal if we consider the lung durability, because the non-circle shape of the biopsy stent maybe in the long term can injure the non-durability of the bioresist wall.
Okay. So we heard that systematic predilatation. Nico, you have also a large experience with bicuspid, and you've been part of all the registries coming from Toulouse. So do you tend to systematically put a cerebral protection device in these patients, or do you do on a case-by-case basis?
No, of course, and again, obviously, we know that we don't have the evidence to support that on routine basis. So far, we're waiting for British data to come next year, hopefully. But here in this particular setting, considering the young age, considering the potential devastating consequence of a disabling stroke, and considering the phenotype, yeah, I would put a cerebral protection device, and considering also the need for several manipulations in the valve.
So cerebral protection, we pre-dilate. We're going to use a balloon expandable platform. Axel, we have different techniques. Now we have reached a kind of maturity in terms of techniques that we utilize for TAVI. Is it different from a balloon expandable to a self-expanding platform? Do you deploy the device in a different way as compared to tricuspid? Do you do a two-step inflation of the balloon? Do you go one shot? Do you go gradually? What would you advocate to the audience?
I think what we have learned in the past that in bicuspid valve, the annulus is usually a little higher than what is indicated by the base of the leaflets. So if you would use this as a reference point, you're probably implanting the valve too low. I think in complex bicuspid patients, I've found it often helpful to have the TOE in place because this helps me much better to understand where the annulus is, especially if the annulus is very large. And then, I mean, on the other hand, I usually go very careful when I use the balloon expandable valve. I go in rapid pacing, I give a first shot of contrast, I slowly deploy, I give a second shot of contrast that I really have visualized the aortic root throughout the implantation. And despite of this technology, it's not a very long rapid phase. In this patient, 28 ejection fraction, I mean, this is some kind of concerning. But so this is how I would do it. In a self-expandable valve, you're a little more relaxed. I mean, if you misposition the valve, you can resheath and just go on. You're more committed with a balloon expandable valve. But I would feel good here with a balloon expandable valve too, given the young age of the patient.
So we have a question from the audience. So thank you.
Also,
usually you have the light on. Yeah.
thank you. And maybe I have more than one question. First, I saw the valve has a different sizing chart compared to the Sapien, and it seems has more overexpansion. So I want to ask, is there any data to show the post-TAVI CT whether the valve has the more overexpansion than the other balloon expandable valve? And second question, maybe I want to ask Professor Chen, that in China, maybe there are more the small annulus patients. Like this patient, maybe not so small, but it's quite young. If for the young patient like this, 69, they may have the chance to do the redo TAVI. And if for the small annulus, will you go for the first TAVI valve with the self-expanding valve or the balloon expandable valve? Thank you.
So 2 questions. So the first question, maybe I can briefly answer before handing over to you, Mao. Nicolas is going to address the issue of, he's going to present the Smart Align trial, and within that Smart Align trial, there will be a CT scan sub-study. So we're going to learn more about the degree of underexpansion because there is systematic underexpansion of all the TAVI platforms, and this is going to help refine and fine-tune the sizing strategy, the sizing matrix. So, but this is a very, very important comment that you raise, because in a contemporary practice, we are more aiming at a 1-to-1 ratio, just to make sure that we get the maximum expansion, the maximum circularity of the TAVI platform that we utilize. So very important comment. And so Mao, short stent frame, small annuli, younger patient, would you use a balloon expandable platform or as proposed for durability and redo procedure, self-expanding?
Yeah, I think the not very good hemodynamic, maybe the small annulus if we're using the balloon expandable device. But to this particular patient, just because maybe we use a 26 millimeter, so I think it's okay because all the hemodynamic data showing us 26 is okay. So if we have some concern about the redo TAVI to this particular patient, I think the first the balloon expandable and followed by the self-expanding device is reasonable.
Thank you very much. So this was a very intense, dense discussion. So it's time to go to the case itself. Yeah. So we're going to see the outcome through the recorded case.
Okay, so this is how procedure went. Again, my disclosures. Yeah, so as we discussed before, for various reasons, generic, not necessarily related to this valve, is also current stage of experience. Decision of implanting team was performed pre-dilatation. It's either, you can use either dedicated TAV zero balloon, which is from Venus, or alternative, any proprietary balloon. So in this case, as you can see, the pre-dilatation was performed with 23 millimeter proprietary balloon. As a guide wire, it was utilized Safari extra small, which is workhorse, as we all know. So this is the dilatation.
Okay.
Yeah, so as we already see, this nice sheet, this Absopath sheet, which is really, once you are in, it's very, very easy, smooth delivery of that system access and your docking. with locking system, which then keeps in place when you start putting the valve. So you can see easy travel. I mean, this anatomy geography was quite favorable here, so no problem was encountered. When you lock it, it's going up nicely. Okay, and then once your delivery system is docked to this absopath sheet delivery system, then you advance pretty much with the steering knob. So as you can see on sideways on simulator and real life, I think that's on play. Yeah, so again, you've seen with other valves, so it travels quite nicely over the arch in this anatomy. Again, as I said, this is Safari wire there. Okay. It's nice, careful, trying to minimize contact with the arch, getting onto the valve. Okay, and then Axel already mentioned there's a feature, there's a steering knob and got this telescoping knob, so you can actually, which is advantage, potentially with those bicuspid, you can actually, with telescoping knob, you can tweak your position. That's a second grade knob here, with some fine tuning, get it right in a place when you want. You see those markers, which purpose of them is it was not utilized in this case to alignment or cast alignment to be where the coronary arteries are. So here we go. You just cross because it's all of them playing together. They should all start. Yeah, so here you see how you can adjust very subtle movement with the telescoping knob. So you get very subtle differences in your positioning. It's obviously calm, it's balloon expandable, so patient is stable. So until you are completely satisfied with your markers to have an optimal annual placement of our valve.
So you use the markers both for depth and commercial alignment?
For a commercial alignment, which is that Y connector, which you'll see later, you can adjust, you can rotate around for desirable position. And again, we already said in our planning of procedure, we use this calculated 23 milliliters at 7 atmosphere. The one feature, which again says is locking wire. So again, because this is going to be to various geographies, sometimes challenging anatomies, a lot of bicuspid in China. So the locking wire is actually holding just in case to prevent any big problems or anything, just prevent valve descending to wrong place as a safety measurement. The locking wire, which is kept in position typically during valve inflation. So here pacing, you see it on inner curve with the markers. That's that locking wire. So it's there.
Yeah, we see
until you are pH. It just keeps there until you deploy the valve. So deploy it very much like balloon expandable valve mechanisms. And here we see the valve is deployed. It's sitting very nicely. You see all those markers. You can consider post-dilatation in those difficult anatomies like bicuspid. But here on aortogram, see that is very good. You don't see any leak. You see patent coronaries. And the locking wire is still in a position. So you could take it out before if you are confident, but it gives you this extra safety feature. Because again, we go to markets with huge numbers experience, but also obviously all world needs to treat aortic stenosis. So it gives them extra safety feature to prevent any major problem in dislodgement. In this case, anatomy is so good, the result is so fine that you did not need any post-dilatation. And then lock wire is removed. Prior removing the delivery system, you disconnect from the wire connector. The wire connector rotation used for alignment into cusp in relation to coronaries. So it's attached to that, so you just remove it into the delivery system sheath. And then very much generic when you unsteering and withdrawing your nose cone to be just about this absopath sheath for full extraction from the body. So again, you see, got nice gentle pull. So it's again, it's a skill which many operators already obtained. Yeah. So. Anyway, yeah. So again, this is the final.
Let's play it.
Final position when all catheter devices are out. Pretty good result. High position, no leak, patent coronaries. So it was quite satisfactory. So this is exciting new technology. Early days, the procedure itself was. As I said, it's thanks to we currently do procedure in a lot of experience centers outside Europe, hopefully coming to Europe very soon. We will hear in a moment a trial, very excited. So this goes thanks to team in Medicina Cardiovascular Asociada in Santo Domingo. So again, aspiration is to address all contemporary problems with valves, same time to be available to widest possible geographies. It's fair, all patients in the world will get chance to treat aortic stenosis. Thank you very much.
Thank you very much, Jan, for this nice demonstration. We see a next exceptional outcome for this bicuspid patient. So I'm sure that you will have a couple of questions or even more about the device, the technology. Feel free to either directly come up to the microphones or to send to Axel your question, and we're gonna address them. Nico, maybe we can go more into the academic aspect of the technology and what is in the pipeline in terms of study.
Yeah.
Would you drive us through the Smart Align trial?
Yeah, with pleasure, Didier. So the Smart Align study, that is the CE mark study, will be, as you will see, a prospective multi-center, single-arm, non-randomized interventional study targeting patients with severe aortic stenosis who are clinically indicated for TAVR per the heart team judgment. And we'll cover that in details. It will enroll around 150 subjects, up to 20 sites. And we're going to detail the characteristics and the design of a study. So overall, the objective, as you understood, is to evaluate the safety, effectiveness, and performance of a venous vitae transcatheter heart valve system in patients with severe aortic stenosis. What about the inclusion criteria? I would say quite conventional for such a CE mark study. So of course, patients within the range of age to be eligible for a TAVI procedure, having symptomatic severe aortic stenosis with a usual echographic definition. So again, quite, I would say, usual criteria. What about the exclusion criteria? No need maybe to cover all of them, but I would say I would highlight those ones that are just here to make you understand that, as usual, again, in this setting, there will be a pure population of aortic stenosis patients enrolled in this study. So it means no patients with multiple heart valve disease, no patient with unstable other coronary or clinical conditions. And of course, anatomical obvious exclusion criteria, no patient with too poor left ventricular ejection fraction or other anatomical conditions that could interfere with the outcome of a procedure within the trial. So the endpoint, the primary safety endpoint will be all-cause mortality assessed at 1 year, while the primary effectiveness endpoint will be defined as acceptable bioprosthesis function at 30 days by TTE. It will be core-lab analyzed and assessed on aortic pressure mean gradient below 20 millimeters of mercury and less than moderate aortic regurgitation. Few words about how the sample size was calculated. It was based on literature assessments of both the primary safety endpoints and the primary effectiveness endpoints, but ended up to this calculation of 150 subjects. Of course, conventional secondary endpoint, technical success, device success, focused endpoints of hemodynamic performance on the valve. Didier mentioned that, and it's, I think, an original feature of this trial that there will be a sub-study CT sub-study that we allow for better understanding of valve deployment and also coronary alignment, as you understood that this device offers the feature of tailored coronary alignments. And of course, the usual secondary endpoint. So this is the overall study trial flow chart. Again, quite conventional one. It will be a multi-center international study, so centers enrolling in Europe, but also in China and in Canada. The regulatory process is ongoing, and the study is about to start, I think, early next year.
So thank you very much, Nico. This is a very exciting study, and I'm very much looking forward to get it started. We're going to learn more about what this new type of device is going to bring to our patients in Europe, because the features are quite impressive: short stem frame height, that commercial alignment ability, the 4 valve sizes. We saw that PV leak was not an issue at all. So, but maybe Axel, there is something else in the pipeline that you would like to.
I think it's
Mao. It's Mao. Mao is going to
he
speak
knows
about
all the
pipeline.
secrets.
Mao knows everything about.
To be great honor to introduce Venus MedTech pipeline and expanding device another type. So this is my disclosure. And I think the Venus innovative technology family will show you the quick view of the whole pipeline device. I think Venus is the leading industry in mainland of China. They cover not only the transcatheter aortic valve replacement, and also cover like the mitral space, the tricuspid space, and the pulmonary space. Also, they have some special tools for the hypertrophic cardiomyopathy. We call it the 11 radiofrequency. Here should use a different level device in this pipeline. We know the like the safety band device, followed by the Venus A. We have the Venus Power X and the Venus Vita. We have looked and we have the Dragonfly for TL, transcatheter 80 to 80 repel, and the cardio valve for mitral replacement and the tricuspid replacement. Also, the Dragonfly just adjust for the tricuspid rotation. The Venus pulmonary valve gets the certification not only in mainland of China but also in European market. Other is the 11 radiofrequency ablation system for hypertrophic cardiomyopathy. I just introduced the Venus Power X. This particular device has some features, for example, the dry tissue, and the major advantage of this particular device is 100% retrievable even after full release of the valve. That means the fibrosis stent have been completely open. You have the chance to retrieve this device and the control of the valve, and also the safe adaptive tissue just for prevention, the PVL. I showed you fibrosis stent made from the retinol and dry tissue. It's a porcine tissue with some spatial classification technology. The safe-depending PU form skirt to prevent the PVL, and the 3 golden markers to make sure the possible the placing position, and just the outflow part have the 3 notch valve strength to preserve coronary access while retaining a high radial force. Should use the leakage prevention technology, high compression ratio, and self-expanding. That means it's kind of active sealing expands outwards after absorbing blood. Should use delivery system, and I think the major feature of this delivery system just follow a release of the wire control the stent. And by this particular delivery system can achieve the 100% retrievable, and the sheets have some unique design, and the preload is very important. Can keep very short preparation time to under 2 minutes. And the follow the suture control and release system can make us to 100% retrievable. Here should you the cartoon of this particular device. The frame design about 40 millimeter, so a little bit shorter than the routine self-pending device.
And we have the same marker for commissural alignment once again.
Yeah, but not this. Just because we just make some experience how to get the real commercial alignment. I think the major advantage is personal to me. I think very important to bicuspid and hip calcification patient, just because we can find even final deployment of the routine servipan device. Sometimes we can find the later migration of the bioresistant. So if we can open the bioresistant total, if we found the position is not very good, we can retrieve and adjust the position afterwards. So we have finished the film study, and including our center and Creantis center in Argentina. Not this, we think the film study should assay the immediate walk-through technique success 94%, just one patient with the major vascular complication, and 30 days walk-through device success close to 90%, just because some patients have the pacemaker implantation, and no mortality, no stroke, and no valve intervention. And the valve function looks good. The hemodynamic improved afterwards, and left ventricular ejection fraction a slight improved. No AVR, no AR, that means the high than moderate. So I think it's a spatial design self-pending device. Thank you very much.
Thank you, Mao. So this is quite impressive for portfolio first, because we can see that all 4 valves are covered, in fact. That should be beneficial for our patients. But I'm even more impressed by some of the features of these devices. If we start maybe with you, Jan, and we come back to your case, we've seen that the vitae is encapsulated. Do you think that this could help us to achieve shiftless procedures? We could get rid of the shift? Do you think that it's feasible?
It's quite possible, and it's aiming for it. And then you have a wider variety of femoral cases. Yes, I think so. I would just add on, if I were it, what's exciting is you got full scale on both valves. They are addressing problem in contemporary valves. They are addressing alignment. You can actually, is error prone connection either of them until it's over, it's not over. So it's increasing safety, giving you alignment, and I got all other features to prevent leak, plus dry technology. To me, that would be things we'll be talking on London Valve in years to come.
Yeah.
Please, Nico.
Yeah, Jan, one question about, I think one of the most original feature here is the ability to really orient the commissures on where exactly the native anatomy is. So, of course, I understand it's limited experience so far, but can you elaborate a little bit more on how you act on that? Is it something that you act on just before deployment, or during a small and progressive deployment, you can still act on the rotation?
You can do rotation, that's one thing, and another thing, obviously, depth is with that micronope as well.
Yeah.
So you can use both to good effect. Then we can, even though it's limited experience where it's now, but obviously aspiration that it will be utilized for long-term durability. Yep.
Yeah, I have a question.
Yeah,
to
please, Mo.
Nicholas. And just in your smart study design, you not exclude the bicuspid patients, right? But I have some question about the type 0. You know, this Vita looks a little bit shorter than the routine balloon implanted device, but we know sometimes we know the frequent the bicuspid always have the longer leaflets. Do you have some concern about diving into the left ventricle? So, how to choose the right patients of type 0, maybe sometimes type 1?
So to that, I would be really honest. In our area, geographical area, the type 0 bicuspid are not really frequent. So we have less experience than yours, for example, regarding selection and technical guidance. So I don't have, I think, enough experience to answer to your points.
But I can imagine this is the first study, works well, it inevitably will follow, whether it be Chinese trial, European trial after that, after this align for this type.
And there will be the CT sub-study once again, and it's going to be extremely helpful to help us understand what is the overall configuration of the stent frame, the degree of potential under-expansion, if there will be some leaflet overhang. But what I expect anticipates that the centers at least are not going to propose these extremely calcified type 0 bicuspid patients at the start. It's going to be more about our routine practice, making sure that we understand more about the device, and then we can gradually expand the scope of patients that we are going to treat in terms of complexity. There is one feature that is really new to me, is that full retrievability of the device. You can fully expand it. The Power X assess everything that you want and then fully recapture it. Do you think that that's something it's available? That's something that is going to be utilized quite frequently?
No, I don't think it's frequent utilization, just because in our film study, we just fully retrievable only one patient. We finish 18 patients, but only one. Just from our data, we found this person bicuspid and have calcification. About 10% patients have a little migration, a little bit. Sometimes maybe we cannot get the file position very good. So I think this particular device is person help us to get the very good result in this particular group.
That's really unique. The only device that had this feature, Nico and Jan, you remember what was the Lotus, and it was really useful because you can expand, assess, and if you are not satisfied, either reposition or withdraw the device and use a smaller or bigger size. So it's a good.
So I think the retrievable function is stable, and according to the industry's recommendation, we have 3 times the chance to retrievable the 100%.
And again, it's marching on TAVI, but we are still not touching world population. So going to many other geographies is additional safety feature. Even you don't use it very often ever, but just gives you that extra confidence when you do procedures. Not everyone's done millions like most people at this table. That's another.
Yeah, it's really something that you repeated several times, the safety, additional safety, both for the balloon expandable and the self-expanding platform. Axel, any question from the audience?
Yeah, there's one, but maybe a comment to the repositionability option. I think when it comes to tall people with an horizontal aorta, you often know that it's extremely difficult to achieve the appropriate position. It depends a lot on the catheter design, and then we are too deep on the non-coronary side, and we almost miss the annulus on the acoronary side. And I think in those patients, this might have an additional value. There's one question, maybe, and Jan, you can answer this, about the capsule on the valve. So the question is, when are you leaving the capsule behind? At what part of the aorta? And is there a chance by mistake to advance the balloon with the capsule all the way up to the valve and accidentally deploy it inside the capsule?
You shouldn't. It's sitting there nicely. No, you shouldn't. No, it shouldn't happen. No.
So it stops very early in the abdominal aorta.
It's way away from.
even if you are very short, you're not going to reach the aortic annulus. But that's a very wise, important consideration that we have. So that's, guys, you said from the wish list of the very beginning, there was durability, there was redo procedure. So having seen that, do you think it's, I'm starting to think about what could be the perfect combination, but do you think that we could mix these platforms in the future? You start with one, let's say the Vitae, and then you move with the PowerX or the next iteration. Then you do that short stand frame, and you put inside the self-expandings that is not that tall. And with that, with this open cell design, maybe we could keep access to the coronary arteries. Do you think that that's something that we could imagine for the future? Axel?
I mean,
we have to be innovative.
Yeah, we have seen all crazy combination of valves inside patients already yet. And we know, I think, from the past that, having a high implant of a self-expandable valve in the past is something that is difficult to deal with in the future if the valve is going to fail. I think with these new technologies, with the frames being shorter, that even if a self-expandable valve fails, and with the new designs with regard to the frame, we are more open to the valve-in-valve procedures. I think, starting with a self-expandable valve often makes sense because you're keeping the gradient low. So when it comes to the valve-in-valve procedure, you might have the longer durability over the long term as compared to starting with a balloon expandable and then continuing with the self-expandable. On the other hand, starting with a balloon expandable might better preserve coronary access in the future. I think with the technologies that we have just seen, both options are viable, and I think this is a good thing for the patient.
I think there are technologies how to deal with leaflets, and we've seen at this meeting, there's one thing to repeat, but at the same time, I'm a strong believer, ultimately, it will be the leaflets durability, which might delay inevitable second valve, and it's why the power itself is dry technology, so you might need your second valve much later, if ever, in population. Remains to be seen, because it's only start with Venus, and obviously some other companies try the same. So if your leaflets are durable, your implant is perfect, maybe valve-in-valve become a lot less frequent procedure even after many years.
So let me turn out to you, Nico, because you did a beautiful demonstration of a TAV-in-TAV, redo TAV procedure. So what are the key considerations in terms of planning that second procedure? What do you analyze?
Two main ones. The first one that is currently, I think, the most popular is the coronary issue and the risk of creating this tube, this neoskirt that might impair the coronary perfusion. So all of this is predicted by the CT scan and determined by the balance between the features of the first device you implant and the surrounding anatomy. But again, this is something that you can at least at 100% predict at the time of your CT scan. The second one, I think, that is less discussed, but even as important, is the sizing. For all of us that have performed TAVI and TAVI procedure, when you look at the anatomy evolution throughout all those procedures, you start with a native annulus that is around maybe 24 millimeter. You implant 29 supraannular self-expandable valve, and then 10 years later, when you come back to do your redo TAVI, the true ID of your degenerated valve is now 20 millimeter. And of course, it's a huge consideration for your sizing for the second procedure. And it questions the idea of having a true lifetime percutaneous management over the second redo intervention.
So it really comes back to your comment from the audience about we tend to oversize a lot, but at the end of the day, the devices are going to be smaller. And that is that dimension post-procedure that is going to impact our ability to do a redo procedure after. Okay, so I have to say that I really much enjoyed the discussion that we had, and it was fun. I learned a lot about we all learned a lot about the portfolio of the Venus MedTech devices. And I have to say that it's quite impressive first and ambitious, and it should be beneficial for our patients. So what did we all learn together? First of all, what are the key considerations when it comes to the index procedure? And something that I will bring back home is that concept of avoiding too much excess of oversizing, because this is going to impact redo TAVI in the future. We've learned that with this type of new generation TAVI devices, we could get excellent procedural outcomes, and we've seen that through your case. And we've also discussed the potential for combining different solutions for a single patient. When you have a large portfolio, you can select the proper device at baseline and anticipating what is going to be the redo procedure. So we are all learning together. We are improving at that, and I would like to thank you for your valuable and inestimable comments, input. I would like to thank you all for being here. It's Tuesday afternoon, third day of London Valves, and the room was almost packed, so it's cool. And I would like to thank Venus for giving us the opportunity to have such a session. So enjoy the rest of the meeting and see you very soon.